A very good afternoon to all my dear friends. I'll be discussing about anophthalmia today. What is anophthalmia? It is a congenital anomaly where there is complete absence of ocular tissue in the orbit. Now, it is a very rare condition. Extreme microphthalmos is far more common than this, and extreme microphthalmos can be mistaken for anophthalmia. What is the etiology of anophthalmia? During embryogenesis, there is arrest in development of neuroectoderm of primary optic vesicle. Anophthalmia can be related to maternal infection during pregnancy, like toxoplasma, rubella. It may be associated with craniofacial malformations like Goldenhar syndrome, Waardenburg syndrome. It may be linked with genetic defect like trisomy 13 to 15, chromosome deletion on the band 14q2223, and deletion in the genes like SOX2, SIX6, and STR6. What are the clinical features? Now, eye is the stimulus for the growth of bony orbit. As there is no eye, so bony orbit will not grow properly. The orbital feature and lid features. Orbital features are reduced orbital rim. It is reduced. The bony cavity is the size of the bony cavity is reduced. Absence of globe in the orbit. Absence of extraocular muscles. Lacrimal gland and ducts may be absent. An optic foramen is small or maldeveloped. So reduced orbital rim, reduced size of the bony orbit, absence of globe, absence of extraocular muscle, lacrimal gland may be absent, optic foramen is small or maldeveloped. What are the lid signs? Narrowing of the palpebral fissure. They are very narrow. Both the fissures are narrow. Then the lids. There is a foreshortening of the lids. Shrunken conjunctival fornices. LPS, levator muscle action is decreased or absent. There is poor eyelid fold and contracture of orbicularis oculi muscle. So in the lid, what is there? I repeat, narrowing of the palpebral fissures, foreshortening of the lid, shrunken conjunctival fornices, two muscles, LPS and orbicularis oculi. LPS muscle action is absent or it is decreased. Contracture of orbicularis oculi muscle. So their orbital sign and lid sign. Symptom: unilateral or bilateral blindness. Diagnosis: mainly by the clinical features. A B scan of the orbit will show absence of globe. At 22nd week of gestation, if you do transvaginal ultrasonography, eye malformations can be detected. But how much they are sensitive to detect anophthalmia is not clear. MRI and CT scan of the orbit will show MRI will show the soft tissue inside the globe, inside the orbit, and MRI and CT scan will demonstrate any craniofacial malabnormalities present along with anophthalmia. Now, once diagnosis is confirmed, how you treat? So, use medical treatment and surgical treatment. Medical treatment, conformers, prosthesis. Surgical treatment, you have expanders and different surgeries. Coming to medical treatment, conformers are placed inside the orbit. They will stimulate the growth of the bony orbit. As the child grows, you have to replace the conformer with a larger size conformer, and they will stimulate the growth of the bony orbit. So this requires frequent visits. So here the patient and the parent should cooperate. Also, we should explain the parents that we are putting a conformer, the bony orbit will increase in the size, but remember, it will not be exactly the same as the other orbit. Don't expect too much. And also, if a parent stops in between the treatment for a significant amount of time, if the conformer is not placed in the eye, reversal of the benefit gained can happen and contracture of the orbit can happen. Second treatment in medical is ocular prosthesis. Over the conformer, one can place the ocular prosthesis. This will not stimulate the growth, but it will simulate. It will simulate the eye appearance. Okay? And after this, suppose if we cannot go by this, if the parents are not cooperative enough, or by some reason we cannot place the conformer inside, there's a lot of contracture and all, surgery is advisable. Now, not directly surgery, but there are some expanders. First is a silicone expander. It is an inflatable silicone expander. So on a weekly or a bi-weekly schedule, you have to inflate it with a saline. It will expand and will cause the orbit to expand. You have to place deep inside the orbit, and there is a tube which is left at the lateral orbital rim. Now, advantage is that over the conformers, what is the advantage? This will cause a more rapid and an extensive expansion, more rapid and extensive expansion of the orbit as compared to conformer. Second type of expander is hydrogel expanders. For them, you need not re-inflate them. What they do is, they are self-expander. They will absorb the fluid from the surrounding tissue and expand. So they are much better. Hydrogel expanders. Third is you can place a dermis fat graft. It is taken from the buttocks. But with the fat graft, what is the problem? The compatibility and the growth of the orbit which will be achieved will be variable. Because it is a fat, it can atrophy or hypertrophy. Okay. Fourth is injection of calcium hydroxyapatite. It is called as a dermal filler. You have to inject in between, like at intervals you have to give that injections. So it is a new treatment. It is a cost effective treatment, but at frequent intervals you will have to re-inject, and till now it has been shown that the effect has lasted about 1 year or more. So silicone expanders, hydrogel expander, dermal fat graft, and injection dermal fillers or calcium hydroxyapatite fillers. After four things, nothing works or nothing can be possibly done. One can go ahead with craniofacial advancement surgery. In this, multiple osteotomies are made to divide the periocular bone for forward and outward advancement of the orbit. So these are the major surgeries, and one thing I would like to mention, when we are placing the conformer in the medical treatment part, placing the conformer that time, if the orbit anophthalmia is severe and we can't place it inside, what we have to do? Lateral canthotomy or cantholysis. So this was the surgery part. Now, after all this, what is the prognosis for such eyes? This severe cosmetic deformity can happen if early treatment is not done. Severe cosmetic deformity. Second, if treatment is done, things will improve, but expectations should not be set too high. This eye, the affected eye, will not mirror the normal eye. And third most important point, such children should be given psychological counseling because they may have these psychosocial issues because of facial disfigurement. This is all about anophthalmia. So what is anophthalmia? What is a differential diagnosis of anophthalmia? Extreme microphthalmos. Etiology of anophthalmia. Clinical features. How you diagnose and how you treat, and what is the prognosis. Thank you.